So if you could, let's get the whiteboard up and get the learning started.
All right, I will start with aliquot 1. So this is a 35-year-old male with no significant past medical history who was found down by EMS, admitted for hypoxic, respiratory failure, and altered mental status.
Awesome. This is exactly the kind of case I was hoping to get. So a little bit of background. I actually I'm a recovering emergency medicine doctor as well. So I did a dual training. So this is exactly a patient I've probably seen before. And I think there's just there's so many ways this can go, and I think, as someone who's seen a little bit of trauma, a little bit of internal medicine, curricular medicine, like it's going to be interesting to parse out what's at play here. So.
All right, to continue. This man was working as a OR technician until 2 weeks prior to presentation. He stopped working due to concern that he may have contracted COVID. He was suffering from headaches, and due to that, he quarantined. He got a COVID test that was negative 1 week prior to presentation. On the day of presentation, the patient was found down by his roommate in the bathtub for an unknown amount of time, and EMS was called. The roommate doesn't know the patient very well. It is generally unaware of how long he's been there. On EMS arrival, the patient was found in his unfilled bathtub in his OR scrubs. He is nonverbal but arousable with verbal stimuli and intermittently able to nod and shake his head. He was hypoxic to the 80s on room air, but improved with 4-liter nasal cannula and was subsequently brought to the emergency room.
Okay, so with this information, I feel like this is kind of the stabilization and conundrum of limited history available and trying to put pieces of a puzzle together kind of with a limited history. So what are some of the first things that you'd be thinking about stabilization wise, and then also kind of what additional pieces of information would help y'all in working up and developing a differential here?
Yeah, so what's nice about the history so far is that it sounds like it's even included some kind of pre-hospital information, which is, I think, if I'm working, for example, in the ER, this would be, if I see the paramedics bring this patient in, this is one where I think having them stick around and maybe share a little bit about the scene is really helpful. And you've gotten some of those details, which may or may not get us to an answer of what happened. Because they're often very good at describing the scene of what they, as they entered, were there any hazards? They can sometimes give some sense, was there signs of trauma? Which I think is the thing I'm concerned about. Was this a kind of a syncopal episode that landed himself in the bathtub, or is this, some other medical illness that then resulted in a fall, that now really the trauma is the main issue with intracranial injury? This headache that was described a week before, was there some sort of brewing intracranial process like an encephalitis or maybe a sentinel bleed? And then now we've had a much more massive event like a subarachnoid. There's a lot you could go from here. So I think as we talk about, stabilizing is going to be first predicated around the vital signs, but I'm sort of approaching this like a medical and trauma patient where, maybe I'm going to be careful to not, for example, put a great deal of movement in the cervical spine until I get some imaging, which I presume will come later in the case. The bit of history that's interesting to me, I think, is being found in the bathtub with clothes on, if I gather that correctly, which sort of implies some amount of cognitive, like unless it truly was a slip and fall into the bathroom, describes like a bit of altered encephalopathy before finding themselves in the bathtub. So was this patient confused at home? Maybe there's more of a prodrome to this, is what I'm wondering.
Yeah, I think I don't have a lot to add to what Pat said. I think that the first concern in this situation is always safety of the patient, and I think certainly the differential diagnosis, I think, process would sort of be done in kind of in parallel with stabilization rather than in series. And I think, the first question, obviously in these situations with altered mentation, is the person protecting their airway? Do they require intubation for their own safety? And C-spine stabilization, like Pat had said. And then I think, and then in parallel with that, you're sort of working up a differential here. And I think there's a couple of different pieces of information sort of in the background and the foreground. And I think one, so you have kind of altered mentation. You seem to have someone who had a loss of consciousness. We wonder, like Pat, I think astutely noted, that he was sort of in an atypical context, and you wonder if he was altered, that sort of led into that. And then with a potential trauma, and then you have this COVID positive test, which is unclear how that may work in as well. And then this preceding headache. And I guess I would be painting with sort of really broad brush strokes at this stage. And I think thinking about like things like CNS infections like meningoencephalitis, a seizure event, syncope, either related, if we were going to tie it together to COVID, you might say, hey, could you have a myocarditis and arrhythmia, or a PE? And then again, wondering about a primary trauma as well. And then again, depending on the time of year, you think about things like carbon monoxide poisoning and other sort of environmental exposures. Sounds like the roommate perhaps wasn't affected, which perhaps makes that less likely, but those would be sort of my sort of initial thoughts when just first meeting the patient.
Awesome. Now this is a little bit of like kind of something that might cross disciplines, but would y'all be considering giving things like a opioid reversal agent in this situation?
That's a good question. I think, I try to look for something before giving naloxone, something either described at the scene in terms of medications. If there's, if it seems like we may or may not have this patient's name, we're looking at like PDMP, like sort of prescriber databases for controlled substances. I think the exam was critical. If you have sort of, and I know this is stepping forward, but pinpoint pupils, slow respirations, then I might, believe it or not, Narcan's actually does have some, risks. There may be theoretical, but I probably wouldn't unless there's something about the history that made me do it.
Okay, awesome. Well, we would love to hear more, Mary.
All right, I will continue on. So for his past medical history, as mentioned before, he has no significant past medical history. He was actually working in our healthcare system, so we can confirm that he is up to date on all of his vaccinations. He takes no medications, no significant family history. In terms of social history, he was born in Liberia and moved 20 years ago to here in North Carolina, has been working and kind of living here ever since. He's been working as a OR tech for over 10 years now. He has occasional alcohol use, at most 1 to 2 drinks in a week, and that's been corroborated. And otherwise, no drugs, no alcohol, no odd exposures, no allergies.
Mary, I don't know if the time, when this case took place, but just out of curiosity, when you say vaccines a day, is he also vaccinated against SARS-CoV-2?
Mhm. Yes, this happened pretty recently. So within the last, I think it was, yeah, within the last 2 months, this occurred. So he was fully vaccinated against COVID, and as mentioned, he tested COVID negative for COVID a week ago, but because he was still having symptoms, he kind of withheld from coming back and until he quarantined until he was sure. Yes. Any other questions?
I'm trying to think what to make of the social history, if it adds to anything. The sort of employment within the healthcare system. I'm trying to figure out if I should read into, a certain amount of like awareness of potential illnesses, whether that means that this was a much more acute process, because if presumably if there was could know of some very bad outcome, bad illnesses that they would want to identify. I'm trying to figure out if I guess I'm trying to figure out if people who work in healthcare are good patients or bad patients, is what I'm kind of thinking about when I have that information. But yeah.
Yeah, I don't know also if the social history gives us or the other kind of medical history gives us a lot of information. I guess the one interesting piece that jumped out was just sort of place of birth. He was born in Liberia. TB is endemic there. And so, it brings up other, things like, CNS reactivation TB. There's not really a lot else pointed to this in this case necessarily, but it sort of is an interesting piece of history in the background.
Cases such as these, do y'all have any like helpful questions to ask if the patient isn't able to answer, family members that you find helpful in getting some collateral information to help kind of solve these cases with limited history?
I think like if there were, for example, like contact info, I mean, the roommate would probably be the best source of information in this, but I think knowing when they were last seen in their normal health would be critical. So we already have some information about like how he was feeling ill with, fever and symptoms that were concerning for COVID, but like, we know when the roommate found him, but maybe knowing the last time that the roommate saw him, talking, for example, that might be information I try to elicit.
Yeah, I agree. I think timing is crucial. Last known normal, any antecedent symptoms that he might have reported that he can't tell us now. I think, if there's any sense of travel history recently, or any, has there been any kind of contact with the healthcare system as a patient, just thinking about procedures or something like the patient could have had done that is affecting the current clinical situation. But I think the timing is probably the most important thing, like Pat said.
Sure. I can give some of those answers now. So his roommate was not reachable at that time. They are not very close. They kind of essentially share a house together and otherwise don't really talk to each other. His cousin was able to talk with us, and the cousin said they last spoke and hung out about a week ago when he was having these headaches, but otherwise was acting normally and just was kind of worried about COVID, otherwise very functional. I think I saw in the chat someone mentioning question if there's anything else found on the scene. There was no cleaning solutions in the bathroom. The bathroom looked very clean. He was just in his scrubs in the bathtub. There was no blood, no trauma, no kind of signs of injury at the scene. Yes. Sorry, another thing you asked about is any travel history. He has not really budged from North Carolina during this time. It's been very careful about COVID isolation.
Yes.
All right. I think at this time I can give you some of the physical exam, and maybe that'll be enlightening. So temperature was 35 degrees Celsius, temporal. Heart rate 130. Blood pressure was 109/80. Respiratory rate 29. Oxygen saturation 91% on 4 liters, was a very good waveform. Some additional information, he is 6 feet tall, 121 pounds, was a BMI of 16. The general, the patient is thin, ill appearing, arousable to voice, but otherwise can't follow commands. For HENT, his pupils are equal and reactive to light. Oropharynx is clear, no thick secretions, seems to be breathing relatively comfortably. For cardiovascular, tachycardic, regular rhythm, no murmurs, rubs or gallops. For pulmonary, diffuse bilateral crackles, worse on the left than the right. No wheezing, all lung fields, crackles. For abdomen, it was soft, non-distended, non-tender. For neural, he is moving all 4 extremities spontaneously, withdrawing to pain, occasionally groaning, will react to verbal stimuli, but can't do much else. For skin, no abrasions, no rashes. And then reflexes, 2+, bilateral upper and lower, no clonus, and Babinski was plantar flexion.
This is a very good, very detailed exam, which is great. Mary, can I ask just a random, oropharynx, you said clear, so definitely like no bleeding or signs of injury in the mouth, right? Okay.
No bleeding, no signs of injury. His clothes are clean, no signs of incontinence, no thick secretion, seems to be, his airway seems clear.
You read my mind because I was going to ask about the clothes next. so thank you. I mean, my interpretation of this exam is really one of moving me away from trauma, at least when I'm based on what's seen externally. I'm still a little suspicious based on just really the lack of history and the kind of the way he's been found. But if you're asking me which way is the compass kind of pointing, I think it's pointing a little bit away from trauma and kind of more towards like some sort of spontaneous or medical illness. I think that with really the only pertinent being a depressed level of consciousness globally, and really focal pulmonary findings with these crackles. I'm debating whether this is the crackles are really the sign of the primary pulmonary disease, being the issue, or I'm still a little suspicious that this guy found down certainly could have aspirated. So I think that's where my head's at when I hear this story. Moving away from trauma, but still keeping it in mind, thinking more it's a medical illness, but the sequence of which, mental status coming first, then pulmonary findings, or pulmonary findings and mental status, I'm still trying to figure out.
Yeah, and I think, kind of that branch point of kind of trauma and medical is really obviously very, very important. And I think the other thing kind of supporting that is sort of the preceding headache and sort of that there was some, antecedent symptoms that suggest that this wasn't a spontaneous event, or isolated trauma. And I guess there's one important consideration that having worked with Pat, I know he's actually very, very good at this, is kind of determining is this somebody that you can walk away from at the bedside and sort of gather your thoughts, or is this someone that needs to that you cannot leave their bedside? And I think this case feels like the latter. He's not quite as hypoxemic as sort of I expected him to be based on the history. But I think given his vital signs and his kind of borderline mental status at best, I don't know this is someone that I'm walking away from the bedside to sort of gather my thoughts for. And I think the other thing that sort of it would be going through my mind is this someone that even if they don't require kind of intubation immediately for airway protection, are we going to be able to deliver the care required for them without an endotracheal tube, such as things like head imaging, lumbar puncture? Are we going to be able to facilitate their care in a timely manner without endotracheal intubation? So I think those would be sort of the things that I'm thinking about from the sort of kind of treatment stabilization side. And in terms of in terms of the differential, I guess this doesn't really broaden or shrink the differential for me necessarily. I guess the one interesting thing would be sort of the tempo of the mental status, meaning is it seem like is he improving from when he was initially found, which could potentially be consistent with a post-ictal state, versus syncope, where it tends to be sort of a rapid recovery of mental status once they wake up. So I think that would be a question I would try to assess from an EMS. Might be the best people to sort of be able to answer that, if it seems like his sensorium is clearing at all. And I think the other things that kind of make me, that I think the same thoughts about that Pat mentioned in terms of aspiration. I wonder that the RALs, is this sort of a secondary phenomenon related to loss of consciousness leading to aspiration, or could there have been a primary cardiac event? I know this is sort of acute pulmonary edema. And I see some people sort of mentioning it in the chat in terms of kind of cleaning solutions. That's a really interesting thought. And I think another thing to consider here in terms of sort of a toxic inhalational injury. And I think the other piece is just the BMI is a low BMI. And certainly people, it's a bell curve and there's a range of BMI within sort of the healthy spectrum, but it's a low BMI, and you wonder about chronic things like tuberculosis, like a malignancy, that occult malignancy. Males can have eating disorders, and so I think thinking about sort of electrolyte derangements, vitamin deficiencies that could be associated with that. I guess those would be the things that sort of are jumping out to me from the exam.
What are y'all's thoughts when you look at these vital signs? Kind of how do they help, and how does that help triage the patient here?
Yeah, I think someone brought up in the chat a great point, like this could be a septic patient. I think no matter which way you slice, your definition of sepsis, sepsis 2, 3, future, this patient has tachycardia and abnormal thermoregulation. They've got tachypnea. This is somebody that I'm probably resuscitating with a little bit of IV crystalloid, probably starting antibiotics. I think the vital sign that worries me the most of all these is probably just tachypnea, if that's for real. Respiratory rate of 29, that's such a specific and particularly an odd number. So someone took the time to really count that out. I feel like most made up numbers are even, but if in your patient's tachypnic, you should be a little tachypnic. That's a scary sign. So to Dr. Cooper's point, this patient's got a big workup ahead of you. I think, depending on your individual ability to, for example, be at this bedside, I think would influence my decision of very, significant medical decisions like, securing the airway and the tracheal intubation. I think if there's one barometer I'll do is like, would I sign this patient out to somebody else without an endotracheal tube? I probably would not, So I think unless I know I'm gonna be there at the bedside to ensure that, or in close proximity to, while, further tests are done, I think that you know, I would probably intubate this patient sooner rather than later. Because the other bit is, I think it's not improving. Like if it were improving the mental status, you know, that I presume by now there's a decent amount of time from when EMS picked him up in a bad state and his exam is still poor.
And y'all had mentioned sepsis as something that can alter thermoregulation, especially in a younger patient. You know, I certainly have seen some hypothermia in elderly patients with sepsis. Is there anything else for that's like you're thinking of and wanting to work up with that finding, or should just be on kind of the differential checklist?
I think it also makes me wonder how long the person's been down. You know, and I mean, granted, you know, he's in a bathroom, so presumably a house inside with, you know, a thermostat that's going to keep his body warm. But I think the whole, you know, just some dysfunction of the hypothalamus, whether it's like a neurologic injury from a traumatic injury or a, you know, intracranial hemorrhage or some sort of infectious process. Those are the things I think of too for inability to thermoregulate. I suppose you can also think about endocrinopathies, hypothyroidism. Wouldn't quite, I don't know if we're getting much with that. Otherwise, the tachycardia seems a little odd. Just spitballing a few other things that could cause, hypothermia.
Yeah, I agree. I think I would sort of presume this to be septic, at least in the initial phase. I think it behooves patients to sort of view altered thermoregulation to kind of not necessarily anchor on sepsis, but to sort of make yourself be proven that it is not, because early upfront antimicrobials are really important and affect mortality. But I think it does sort of, you wonder about something like an endocrinopathy, like Pat was saying. But I think that would sort of be, I would look for other evidence of that, I think, before I sort of brought that to the front of my brain.
Okay, are you ready for some labs or any other thoughts before we move on?
Okay, I will start out with some basic labs and then you can ask me for more as you need. So WBC was 7.2, hemoglobin was 16.6, platelet was 257, sodium was 138, potassium was 3.5, chloride was 102, bicarb was 21, UUN is 103, creatinine is 3.99, glucose was 160, calcium was 8.7. I did not write the FOS and MAG, but they were within normal limits, is my note. So AST 201, ALT 208, ALK FOS was 332, total Billy was 1.2, albumin 2.8. EKG. Oh, sorry.
Oh no, I'm sorry. I didn't mean to interrupt you, but I just figured as a pulmonologist as well, does this patient by chance have a blood gas of some variety?
He did. I did not write that one down.
No worries
But
if not.
it was not very remarkable.
Okay.
It confirmed that he had the true oxygen requirement.
Okay.
His pH was acceptable and his PCO2 was okay. So.
Okay. I guess like things I'm taking away from this. I mean, obviously that my attention's drawn to the AK, what appears to be an AKI, and what I presume is a patient that doesn't have prior, chronic kidney disease. That's obviously quite striking. With the when you first started off with the CBC, I was struck by the hemoglobin 16 only because I think we see so many people who are, I hate to say it, but a lot of the patients be in the hospital and ICU with other chronic medical conditions. I at first hear 16, I think, oh gosh, that's something's abnormal about that. And well, might be a little on the higher side. Maybe the clinical setting might fit with some hemoconcentration. I forget this is probably a 35-year-old without much other medical problems, and that's a sensible value. But what I'm taking away from the lab so far is evidence of kidney injury, maybe some suggestion of hemoconcentration, liver injury of some kind, although not so high that I would think this fits with like shock liver. Usually that's in like the thousands is the way I think about it. I am curious if not to keep asking for more, but this is one where the patient's not given much more history. Was there a CK by chance that I've checked?
Yes, a CK was checked. It was over 7,000.
Okay. Yeah. So I've been surprised before at how easy it is to get a CK elevated. And this may all be, it's maybe the case that something acute happens, so a seizure can cause CK to be elevated and things like that, sure. But I wonder if this implies a fairly longer downtime than I had initially thought. I think I was thinking something might be a bit more acute, and any patient who's down for enough time immobile, you start to see a rise in CK. 7,000 is kind of on the upper end of that, but I think it's making me, that's the sequence I'm thinking: down for a long time, rising CK, AKI, hemoconcentration. So I'm getting.
Yeah, and the thing to remember too is BUN and creatinine also, it takes a little bit of time to rise. It's not just like an instant injury to the kidney and the BUN and creatinine immediately rise. So this does suggest sort of a longer process, and I think the unknown downtime is certainly intriguing in terms of kind of what Pat was saying in terms of potentially rhabdomyolysis to sort of explain the renal failure, maybe some hypoperfusion leading to renal hepatic injury, and I think also we always try to sort of use Occam's razor and to try to sort of explain things as succinctly as we can. And then the question, becomes partly, is this renal injury the cause of the problem, or is this sort of a secondary phenomenon, or related to some underlying unifying diagnosis that sort of explains the loss of consciousness or renal injury, pulmonary injury, all of the above. And I guess it feels a little early to sort of, in the absence of like chest imaging and other things and head imaging, to sort of anchor one way or the other. But I guess those would be the things that are going through my mind is, can we sort of explain this metabolic disarray from as a secondary phenomenon related to, say, prolonged downtime and or rhabdomyolysis, or is there some underlying unifying diagnosis that is sort of explaining all of this?
So just kind of a few follow-up questions. What are your thoughts on seeing that low albumin in kind of a 35-year-old patient? Does that point y'all to kind of anything, or kind of raise any specific thought processes?
That's a great pickup. Again, this goes to, I think, seeing too many sick people in the ICU for so long that you forget what a normal albumin is, right? Everyone's in this call is probably closer to 4, so that's a great pickup. I think, low albumin like that, it's either, decreased synthetic function by the liver. I mean, while we have signs of liver, elevated transaminases with normal bilirubin, and I would argue with normal platelets, even though platelets can be an acute phase reactant, I think like cirrhosis and sort of end stage decreased production is probably less likely. So then it could come down to, as someone brought up in the chat, like losses such as, nephrotic syndrome. The exam hasn't quite given that. You would think you would start to see a little bit more in the way describing of edema, periorbital edema or otherwise. But certainly like urinary losses of protein, And then to Dr. Cooper's point, and when we comment on the BMI, a patient, the BMI is 16, while again, could be very within physiologic parameters for, a bell curve distribution, is there any sort of, kind of malnutrition that's been purposeful, as sort of, an eating disorder, that could be a potential explanation for it.
Yeah, I agree with Pat. I mean, I think it's always a question of kind of, what is signal and what is noise? And I think that in combination with a low BMI makes you wonder about something chronic, perhaps, that has been undiagnosed. But yeah, those would be the sort of the things that would come to mind.
And then in someone with a lower BMI, would there be any caveats to kind of looking at the BUN and creatinine that we should just be aware of, thinking about it in the patient, in the context of the specific patient?
Definitely with that, the trend is with, lower muscle mass, the, creatinine, a normal creatinine for this person might be, something much lower than what we would anticipate, something like, so I guess it accentuates the fact that there is a significant renal injury, because, the baseline, sort of amount of, it's a little bit of a just so, but, creatinine floating around in the blood, from, in correlation to the muscle mass of the patient would be lower at baseline.
Thanks so much. Any other tests or images, kind of what would be the most important thing, next steps in workup?
I think this is one I'd be picking up the phone to CT, saying we're on our way to get a CT of the head, and I would also get the cervical spine while I'm there. I probably would have called as the patient was getting roomed and getting his blood drawn.
Would you get the CT of the chest at the same time?
That's a great question. Sort of the pan scan, if you will. And if you're gonna, and I'm guilty of it. I guess in terms of what's the thing I want most is definitely the CT of the head. Because really nothing else besides, admittedly, the BUN of 103, potentially being consistent with azotemia, therefore uremia. Not much else has given me why this patient is so profoundly encephalopathic. So it's really the CT head I want. I think it really depends on the sequence of things. I think if as this is happening, I get the portable X-ray, which shows, some sort of pulmonary finding, I might not be sending them for the CTP study, but and certainly I'm not, although one can debate the validity of contrast induced nephropathy, I think I might not run to that CT chest with IV contrast for PE right now with this AKI until I've got some other data. But I think the CT head is the thing I'm most curious about.
Was there a lactate? I may have missed it, but.
Yes, the lactate initial presentation was 4.7.
So, we can kind of debate all day about the utility of lactate. And I think, in this situation, it doesn't sort of sway me one way or the other. I think, again, you still think about tissue malperfusion. You think about seizure. You think about sort of undifferentiated sepsis. But, I think from an evaluation standpoint, I would agree with Pat. I think before sort of committing to contrast-based studies, I guess I would want to have some additional data like an EKG, like a chest X-ray, just to sort of get a better handle on what we can adequately explain and what we can't. And then I think a tox screen as well is probably helpful. Honestly, for some, things like Tylenol and stuff, it seems less likely. But I guess could he have overdosed on Tylenol from taking for headache? I mean, I guess you could explain it, in other ways. So I think sort of getting a screen for that would be helpful.
Yeah,
Sure.
so I'll not to steal from the chat too much, but these are some great thoughts that people are sharing. I mean, I think a APAP and a salicylate level are pretty easy to get, and are kind of they're sort of a can't miss. A salicylate toxicity. I don't know that we're getting that he was taking a bunch of aspirin or things like that, but certainly you could get pulmonary edema that's non-cardiogenic. You could get a sort of mixed metabolic acidosis with respiratory alkalosis that may end up kind of giving you a quote normal ABG. Although I don't think since we're not giving the parameters, I'm leaving to guess that it's not severely out of whack. So I think an APAP and salicylates are a great idea if those were things I got.
I will say is just an interesting North Carolina pearl that I did not know before moving here. Goody powder and BC powder are very big here. So salicylate overdoses are not uncommon, unfortunately.
Yeah. And some people don't know that they're taking, like you said, there's these products that contain salicylates that people don't necessarily, think of. And one of the most potent things of salicylate is actually oil of wintergreen. It's got crazy, it really could be a teaspoon or two is enough to get toxic.
Okay, some more labs that was asked. The tox screen was negative. Tylenol, salicylate, and alcohol levels were all undetectable. The EKG shows sinus tachycardia, nothing else. And then I think we can go on to imaging. He did get the pan scan donor of truth after he was fluid bolus, and the CT head, neck, abdomen, and pelvis were all unremarkable. I will show you the CT chest if I figure out how to screen share. So, 1 second. Were you guys able to see it?
Yeah. If you don't mind playing it again, that'd be.
Yeah. I'll try to freeze it in the middle so you can see a little bit better. Just past the carina.
Not gonna lie,
There's another
was not expecting the CT. This is not what I thought we were gonna see. I was thinking you were gonna show me through the really the mediastinal views with contrast. There's gonna be a big PE, and I was gonna feel like a big dunce for really sitting on this PE with a heart rate of 130. But no, instead you've shown me this really wildly abnormal CT with a lot of interlobular thickening, ground glass, seem to be left greater than right. A few kind of paraseptal emphysema, kind of blebs. I think I saw one on the left. Sort of acute on chronic kind of CT is what I'm taking away from this.
Yeah, I share Pat's sort of surprise. I mean, this is extraordinarily abnormal. And some of this stuff does take time to develop, like he was saying. I mean, it's almost like they look like cavitary consolidations. And I think the differential, it certainly kind of focuses in and makes you wonder if, about, again, to me, it anchors on the chronic component to this, if this is sort of acute on subacute or chronic. And I guess, we think about infections, inflammation and malignancies, I think is sort of the three that would sort of be coming to mind for me. Infection wise, I mean, I think, I don't know. Do you guys get histo in or blasto in North Carolina? We certainly get a lot of it here in Ohio. I know it's sort of an Ohio River, kind of Midwestern thing, but I think sort of fungal infections, mycobacterial infections like TB or non-tuberculous mycobacteria, I think are sort of on the differential. I think you would sort of still treat this person for bacterial pneumonia as well for something superimposed, and there may be aspiration on top of it, which makes this chronic process look worse. From an inflammation standpoint, I mean, I think, you think about things like vasculitis. It seems a little bit atypical for like an acute ILD. So I think with the, you wonder about something kind of affecting the kidneys and the lungs at the same time. And then, and in terms of malignancies, I mean, I think that has to be on the differential as well. Things like, especially as someone who's a non-smoker, something like adenocarcinoma, sort of spreading sort of lipidically all over the place. So I guess those would be sort of the three broad categories I would sort of be thinking about.
Yeah. Which, maybe you could have some, paraneoplastic effects causing encephalitis. That last bit, the malignancy, kind of made me think about it. Like, did you have leptomeningeal spread? That's not something you're really going to see on CT head. I'm also struck by the absence of something on that CT, which makes me feel like a little bit of a dunce. I did not see an endotracheal tube, if I recall. So I feel a little hasty, as if I was hasty a little bit earlier. But that speaks to, I think, whoever was there, kind of getting a sense of, okay, this is someone I'm stable to send to the CT scanner, and not just for a short scan, but for a much more pan scan.
So I guess just a few follow-up questions. One of the difficulties that we encounter is when to give contrast when there's a component of CKD or an AKI. And obviously some new studies have shown that maybe that has been overblown. So do y'all have a specific kind of strategy or approach to that?
I'm guessing, like, with regards to the CT chest specifically.
Yeah, well, just thinking about, if you feel like a contrasted study was needed, just kind of if there's any kind of approach or pearls that you have when there's an elevated creatinine.
Gotcha. Well, I almost could maybe talk about those separate. So one is, if you're concerned for life-threatening pathology that needs contrast to be diagnosed, I think you could very well make the case you're concerned about a PE, which of course would need to be, obtained with IV contrast. And in that case, if it's absolutely critical that then, I think the risk of CIN, which seemed to be, like I said, perhaps overblown, and even the American College of Radiology, I think, acknowledges that, it's probably not what we thought it was. Then you gotta get the study. I think from a just general, like, when do you need IV contrast for a CT chest? most of the time, what you're getting with the contrast, outside of the acute PE or acute vascular abnormalities in the chest, is, when you're trying to look at, mediastinal lymph nodes that enhance. So you're trying to look at, certain pleural pathologies, maybe a little bit better. But I think on a whole, you get a lot of information with the non-contrasted CT study when you're just looking at the parenchyma, and part of that's just because of the very different attenuation that exists between air-filled structures and tissue planes create such a great contrast that most of the time we get by without IV contrast.
I totally agree with Pat. And I guess the only thing I would add is this is someone that if you're sort of on the fence and because I think thinking about PE is very reasonable in this case. I think from a kind of one component is do we have like a wildly abnormal parenchymal X-ray? So we don't necessarily need to invoke a pulmonary embolus to sort of explain respiratory failure or hypoxemia. Which sort of would make pulmonary embolus potentially less likely, but not excluded. Of course, it's not excluded. But then there's also the value of point of care ultrasound. And so I think, this is someone where you can look at the RV, get a quick look, and just make sure that it's, because a normal RV doesn't exclude a PE, but it sort of makes a big one a lot less likely. You can do a quick DVT study at the bedside, if there's, seeing clot versus not is, again, it's none of these exclude PE, but if you're sort of weighing the sort of the Bayesian pros and cons of doing it, especially in someone with renal injury, I think, again, it's controversial whether or not giving them contrast would make it worse. I think that can be a helpful tool to sort of adjudicate that decision.
And then thinking about this data that we have, what would be your next steps? And then based on your differential, would y'all want to start any kind of empiric treatment based on what's on your differential, and kind of how would you go about thinking through next steps?
Well, so I think I would. That's a CT that's itching for a bronchoscopy and BAL. That's just begging for it. I think every pulmonary fellow and attending wants to get after that. And I think the things you could send off that are just so numerous. You get your cell count. Would be very, I think, interesting. I think getting even cytology, if you get a good sample, would be really, really neat and I think helpful in establishing diagnosis. I mean, we're lucky to have the ability to run a lot of different fungal antigens off of BAL fluids that, I think looking at that would be helpful. I think, given the tenuous nature of this patient, to do that, I might have lost you. I think I froze.
I still hear you, Pat.
Oh, okay. Just the tenuous nature of this, I mean, that's going to require the patient be intubated to facilitate. So if that's already in the trajectory, or you're at all thinking about it, now that I have this and I want more information, I think I might force my hand a little bit more, because I don't know that your non-invasive testing like urine and serum antigens, fungitels, et cetera, I don't know that those will be good enough to come up with the answer here.
I totally agree. I mean,
do you feel like a quant gold would, or a PPD would add any value here, or no?
I don't think it would. I think I'd still want to send acid fast. I think I'd send an MTB PCR off of the BAL fluid. I don't know if it would. If I was really committed to a non-invasive form of this workup, I guess I'd send it, but I don't know that it'd come back in enough fashion or really change my ability to diagnose what's going on here.
I totally agree. I mean, the performance characteristics in active TB for either PPD or quant gold are actually pretty poor because of anergy, and so I think it's something that probably would be sent, but it probably wouldn't necessarily change management. because I think this person really needs invasive testing like bronchoscopy, lumbar puncture. So I think you do send the non-invasive workup, looking at, your analysis, looking at kind of vasculitis serologies. But I think, Legionella, things like that. But I think ultimately this person really needs a bronchoscopy and a lumbar puncture.
Okay. So for this patient, he got the lumbar puncture before the bronchoscopy. He actually successfully avoided intubation during this time. So the CSF had opening pressure of 22, glucose 63, protein 37, one nucleated cell, 40% lymphs, 60% mono/macrophages. Cultures are still cooking, but negative gram stain. And then for the bronchoscopy, I apologize, let me see. Bronchoscopy was done on bilateral lungs, so the right middle lobe as well as the lingula, since he had bilateral infiltrate, and it looked kind of different on both sides. But they were pretty similar. On the bronch, one nucleated cell, one RBC, 100% other cells, not lymphs or neutrophils. Bacterial cultures negative, gram stain negative, AFB fungal or cooking, and didn't result for a few weeks. During this time, well, I guess I don't know if I should just kind of give the course at this point, or if you guys want to kind of think about what you would do once you have these information.
Yeah, Pat, do you want to weigh in?
Well, just that when I hear the term other cell on a BAL diff, that concerns me. that concerns me for, I guess my mind goes to malignancy, that isn't able to be well described on the, it kind of depends who's reading these. If you're cytopathologist that does all the BAL consults, or if it's a tech that reads that, you kind of get different reports. Yeah, I think the opening pressure doesn't bother me too much. I know it came up in the chat, but opening pressure can be very sensitive to things like patient agitation, body position, stuff like that. Although the upper limit of normal being 20, 22 doesn't necessarily jump out at me too bad.
And did you report on what the EOs were?
I didn't write down the numbers, but I actually did the bronch. The yields were excellent.
No, so were the eosinophils, was that?
Oh, you said the EOS. Yeah. I thought you asked for the return. I apologize. No EOS.
Okay. Yeah, and so I think someone just brought it up. I think checking HIV would be something I think I'd want to make sure. Anytime you sort of think about TB, you should think about HIV sort of at the same time. If you think about one, you should think about the other. And so I think that sort of you start to wonder about besides TB, besides malignancy, you think about pneumocystis and sort of other again infections that can be chronic. But you still do wonder about something affecting the brain and the lungs at the same time, like TB, like malignancy. People with HIV can have, lymphoma, which can sort of pop up in different places. And then, thinking about other kind of more esoteric and things like nocardia, just, other, the specter of an immunodeficiency like HIV sort of opens up the differential quite broadly. But I think those would be sort of the things that I'm starting to think about. A chronic infectious process, we said, like TB or malignancy. But
Would y'all
TB,
be
I guess TB would be my highest concern at this point.
Yeah, especially if PCR was not available, would y'all be considering starting RIPE therapy or a TB regimen while awaiting results?
I'll humbly admit I think so just to give you context, we come from a center that I would say doesn't have a lot of TB. So I think like it would be, we like, I personally will admit I don't have as much familiarity, and I probably would not be making that decision in isolation. I'd probably be involving like our infectious disease consultant if available. I mean, if you don't have PCR, it might have ID either. I'm a little bit paralyzed in that decision, I think, to be perfectly honest.
Yeah, I think we'd be working really closely with infectious disease. I think a more pressing question and sort of the immediate is like, should this person be in airborne isolation? And I think the answer would be yes, until the dust sort of settles. I think, it's interesting. Like Pat says, I think we would be working with infectious disease on that decision, but I think the threshold to treat with RIPE therapy, when you have a clinical syndrome consistent with TB, but you don't have a confirmed acid fast growth, is low because it can take time to make the diagnosis. And something like tuberculous meningitis is really morbid. And so I think you would sort of be, be wanting to make that decision quickly up front. And I would think you'd have a low threshold for RIPE therapies because of that. I think the other sort of kind of decision point that would come across my mind, that Pat probably dealt with more in the ER, is sort of whether to give steroids at the time of a lumbar puncture. And then, so essentially, the main reason would be in case the person has bacterial meningitis by, but I think from like pneumococcus, but I think, I in this situation, and actually for TB meningitis, steroids are sort of part of the package. But I actually would be a little bit hesitant in the upfront setting, just given these cavitary consolidations and nodules, and sort of not excluded a severe kind of systemic fungal infection, which steroids would potentially make worse. I guess I would be a little bit hesitant to give steroids at the time of a lumbar puncture. I don't know, Pat, what would you do?
Yeah, I mean, I know from really from a lumbar puncture standpoint, I can't say that I've, and maybe it's because I'm not following the guidelines as well as I should, but I guess I haven't gotten in the habit of giving steroids to somebody who I'm performing an LP on, because I think like the data is best for strep pneumomeningitis, and I think we're grateful to kind of have a system where we can like send off like a rapid, what we call like biofire. It looks for PCR to strep pneumo, so we could probably get that answered quickly. As far as, again, I'll just humbly admit my own knowledge of, say, like TB is something that is less common where I've trained. So I admittedly, wouldn't have thought about it from the TB meningitis standpoint at the time of lumbar puncture. But I think I would still have enough concern for a systemic, fungal infection that I wouldn't be jumping itchy for it either.
This case definitely makes us appreciate all the amazing subspecialty care and that medicine is teamwork. In this case, kind of while thinking about everything, malignancy has been mentioned several times, but it's a younger patient. Kind of any specific malignancies that should be kind of on our mind, or any kind of further physical exam or anything else that we should be kind of thinking about?
Yeah, it's a great question. I feel like I'm guilty of just thinking that just more on the CT pattern, the CT chest pattern. As Dr. Cooper mentioned, if you're thinking about a lung cancer, this wouldn't be a great image for for most of them. I mean, it's not a dominant mass or anything, and certainly the history is somebody that's not, not reportedly a non-smoker. So that's why we brought up things like adenocarcinoma, other adenocarcinomas in the GI tract, or gosh, I don't know, Avi, what do you think? I feel like I did throw that out there, but I don't know which one I was thinking about most.
Yeah, I agree. It's hard to sort of point one way or the other. I think the imaging pattern, could be consistent with adenocarcinoma. There are even things like there's actually a case report in chest just last month of a miliary mesothelioma, which would again be very atypical here. But so you can have malignancies that present in a miliary pattern. Angiosarcoma is one that can sort of present in a younger patient as well. But so I think, but it's hard to sort of anchor one way or the other. But of the lung cancers, primary lung cancers, adenocarcinoma would sort of be top of the list. Non-primary lung cancer, angiosarcoma for me would sort of be top of the list of the malignancies.
Okay, Mary, do you have any additional information?
I can give the conclusion to the case around now if you guys are curious, but once you guys are ready.
Do you want to kind of share any final thoughts before we hear about the case resolution?
I think the discussions are really good. I don't think I can give much more without giving away the ending, to be honest. So sorry.
Pat, what's your money on?
Oh man, I think, I don't know if Mary, this was a slip, but I'm gonna go with TB. I'm gonna go with TB only because it's something you said.
Yeah, I would lean on, I would think TB would be highest on my list as well. Again, sort of looking at things that can sort of explain the loss of consciousness, the abnormal chest imaging, the sort of sense of subacute or chronic kind of presentation and decline, some of the epidemiologic risk factors in the background. I think TB would probably be highest on my list as well.
I apologize. I should have mentioned, yeah, he is HIV negative, tested both for antibody and viral load twice.
High index of suspicion. I like it. All right, Mary, don't leave us hanging. We got to know.
Yeah. So just to kind of give you the course of what happened with him, he got resuscitated with fluids and started empiric broad spectrum antibiotics, was quick improvement of his tachycardia and his AKI. It resolved very fast with them. As you might have noticed, I left out the final culture data on the LP and the bronchoscopy. So bacterial cultures were negative, but both the CSF as well as the bronch was positive for AFB and confirmed to be tuberculosis. We didn't ask for it during this time, but he did also get a blood culture, AFB, that was also positive. So yeah, it was TB all along. He did get cytology, it was all negative, and given his very infectious looking picture and the fact that he was admitted under a medicine team staffed by ID doc, he was started on brachytherapy immediately. He actually after starting brachytherapy, he started to wake up and successfully avoided intubation this time. So yeah, he is doing well on monitored drug therapy now.
Thank you, Mary, for
Wow.
presenting such an amazing case and so well put together. Pat, Avi, any final thoughts?
No, what a wild case. I mean, just trying to, I mean, again, I'll just say, as someone who doesn't see a lot of TV, thankfully, you know, this was a really kind of really fascinating, presentation. Wow, very cool.
Yeah, I agree. I think this is a fantastic case, and I think it really demonstrates a lot of the principles of clinical problem solvers that you all emphasize, in terms of kind of what's foreground, what's background, what sort of epidemiologic risk factors can sort of should sort of tickle your brain and say like, hey, maybe that this brings up another possibility, and then and I think also thinking about Hickham's dictum and Occam's razor, and can we. And I think it behooves us to always try to search for parsimony in diagnosis, and seeing if we can find a single underlying cause that sort of explains all of this. And I think this case really highlights that very well. Obviously, it doesn't always work out, but I think this case highlights that beautifully.
Okay, well, amazing discussion, Pat and Avi, and thanks so much for joining with your busy schedules. I know Pat's on the SICU, and Mary ran from clinic to be able to present this case. And I know everyone's really busy, so we really, really appreciate it. We're gonna finish up with Deborah emphasizing some of the amazing teaching points that y'all made throughout the case. So thank everyone so much for tuning in.
Hello, everyone. Great case and great discussion. Talking about the teaching points about this case, like the AMS could be a trauma, could be a history of syncope, of medical illness, or trauma injury, and the headache could be encephalitis, or a CNS infection. And then in this case, the time is crucial. If the patient has recently traveled, if the patient is improving or not. And then the hypothermia, the causes could be neurologic, hypothyroidism, tachycardia, and the patient presents the CK elevated, and like the differential diagnosis was rhabdomyolysis because presented with elevated transaminase, renal failure. And the low albumin, some causes could be the liver by cirrhosis, nephrotic syndrome, malnutrition, and protein losing enteropathy. And then when the CT presented cavitary consolidation, the three differential diagnosis was infections, inflammation, and malignancy. By infections, fungal and mycobacteria, inflammation, some vasculitis, and malignancy could be adenocarcinoma or unhealed sarcoma. So thank you, everyone. Great discussion. I hope everyone have a great Monday.